Are you going to do a quick introduction?
Yeah, good afternoon, everyone. Welcome to the OHA Crisis Care Guidance webinar. Your facilitator, Rebecca Long here, and we have the host, Dr. David Lehrfeld, and Dana Sullivan is also on the line to give us this presentation today. Go ahead, David. Actually, let's do a quick sound check for everybody and make sure they can hear us.
Sound check good?
Not yet. There we go. Okay, they can hear us.
All right. Thank you all for being here today. Again, I'm David Lehrfeld, the Chief Medical Officer for the EMS and Trauma System, and I wanted to spend a little bit of time to update you on a work group we have developing EMS crisis care guidance for our colleagues around the state. But before we get into that, let's spend a few minutes on the background of how we got here and where we are now. Oregon Crisis Care Guidance. What is it? It's an ethically grounded framework for providing the most efficient healthcare possible in the settings of a public health emergency. And by that, I mean a sustained, severe, pervasive increase in healthcare needs where many are ill and many who would ordinarily provide care are also sick, and the healthcare resources become scarce. It was specifically developed to prepare for situations like the current COVID-19 outbreak. I think this diagram is a very simple way of understanding what we mean by medical surge and why we would need crisis care guidance. This was a model of the current COVID-19 pandemic modeled on New York State right now, and we're looking at one particular thing, and that's ICU beds. The green flat line on the bottom is the available number of ICU beds, and the dashed line, the dashed hump, is the projected number of ICU beds needed. The green area is the margin of error depending on certain factors in the model. So what we're talking about is the difference between the solid green line and the dashed green line, where need is overwhelmed resources. What strategies can we put in place to try to close that gap? Thanks. The guidance provides strategies to increase our ability to care for larger numbers of ill patients with a given set of resources. It also supports the use of limited resources in a just, equitable way. It was initially developed by a broad group of healthcare professionals, representatives from emergency management, local and state public health personnel, lawyers, ethicists, and others who came from all parts of the state. It was most recently reviewed and updated in 2018. The guidance is based on a framework developed by the ethics work group. The group identified key ethical principles that needed to be addressed during guidance development, then took part in content area work groups to ensure that the ethical framework informed each component of the guidance and is reflected throughout the guidance. So there are three basic types of strategies you'll see in the main document. In conventional phase, this is business as usual, where there is no gap between needs and resources. There's strategies for planning for the surge. When we get into contingent guidance, there's strategies for surge capacity. So the need is greater. How do you increase your capacity to fill that need? And then strategies for triage when we get into crisis mode. And crisis is when we have surged all we can and there is still a gap between resources and need. Uh-oh, somebody needs testing. So this is just an illustration using that same graph as before. And oops, I got an arrow missing, sorry. I should never be left in charge of graphics. So we see the same graph as before with the solid line and the dashed hump. and the gap between them that is the need and the resources. When we're talking about contingent surge capacity, contingent level of care, we're talking about raising that solid line up to try to go towards the top of that curve. And that gives us the dashed line, the straight dashed line across. That's when we've increased our resources, we've surged our resources. But at some point, we have no more resources and we've expended all our surge efforts. And then above that line, above the straight dashed line and the curved dashed line is where we go into triage, where we're done surging and we have to ration those resources to fill the need for the most amount of good for the most people in a just, equitable, and transparent way. And this is what the guidance looks like in the document. Same three categories it is presented in a matrix, and each row contains guidance for a specific sector of healthcare, in this case, emergency services. The strategies are divided into three columns. The first, or conventional settings, reflect normal or slightly increased demand on the healthcare system. This is the situation before crisis has occurred, when steps can be taken to plan and prepare for effective healthcare response. The contingent settings reflect the situations in which increased healthcare demand is bumping up against the ceiling of what can be cared for using business as usual practices. Most strategies in this setting aim to increase capacity or surge to care for more people using existing resources. To recognize the value of this guidance, we need to think back to past episodes with severe winter storms and influenza that left many healthcare facilities in the state with high patient census and low numbers of staff numbers to care for them. Many facilities used surge capacity strategies outlined in this guidance to address the situation. In the crisis setting, surge capacity strategies have been implemented and healthcare capacity is still overwhelmed. In addition to continuing efforts to expand capacity, triage strategies are used to guide allocation of scarce resources to save as many lives as possible. So here are a few examples of planning strategies. Developing plans for continuity of critical functions, identifying potential alternate care sites, cross-training healthcare workers, and inventory stockpiling of needed supplies and equipment, such as PPE. Surge strategies would be limiting responses to certain calls, transporting to alternate care sites, modifying EMT to patient ratios, or treatment without transportation. When we get into crisis mode, triage strategies would use objective criteria to evaluate and prioritize calls and determine responses, something that we do on an everyday basis because emergencies are our business. We would also use objective criteria to ensure critically ill and injured patients with the highest likelihood of survival are transported. So what would this look like for EMS-specific crisis care guidance? This is a draft matrix that breaks down the elements of the EMS response into conventional, contingent, and crisis care guidance. Each of these elements in the matrix represents an individual strategy that can be linked to detailed guidance like a table of contents. Throughout the document, you'll find a consistent theme of planning for conventional operations, strategies to increase capacity during contingent operations, and strategies to triage resources during crisis operations. The strategies represented in this guideline are just that, strategies. They're not regulations, orders, or protocols. Each EMS system must evaluate how the strategies may be customized within the context of their individual medical surge plans. Yeah, and if you want to just bring up the guidance, the draft guidance, we'll take a look at how that might work. If we could just focus on that one page there.
Let me get in here so let's see what they're seeing. You just want to see the second page?
Yeah, just the second page. And just the table, actually. There you go. right there. So what this would look like, and again, this is just a draft guidance. These are draft strategies. You would look at your own system and the phases of response, and you would say, this is or isn't appropriate for my system. You know, it is understood that some systems have fixed response, get only an ALS response, get only a BLS response. Some systems are mixed. In some systems, you have choices of destination, and some systems you don't. So this is intended to be sort of a plug and play where you can choose any individual measure that you will want to implement. And then if you just click on that one right there, you want to implement that. And it'll take you to a strategy within the document that can provide you with guidance, and you would look at this and see how you can integrate this into your existing structure. And you go back to the table again.
Is there?
I don't have a shortcut back, no.
Okay.
And this sort of breaks it down into the phases of response. It's understood that many of these things will overlap each other, such as under contingent care and dispatch, you see it says implement a pandemic card. Oftentimes implementing a pandemic card will include medical triage in the PSAP. It will include deploying non-transport vehicles. It will include extended response and to certain calls. And so these strategies are meant to be able to speak to all EMS systems as a whole, with the realization that no one EMS system will need them all or will be able to implement them strictly as displayed here. And if you'll see, as we scroll through the document, it breaks it down into dispatch, response, transport, and destination, and then other logistic issues such as staffing and equipment, level of care, PPE, and where there could be some regulatory changes necessary. And we're trying to keep the look, feel of the broader crisis care guidance meant for the entire healthcare system, but something that really speaks in a functional capacity to EMS. And with that, I think we will go into questions. They're really good or really bad. There's no questions. Let's just go over the document available on the web. I may have missed it. No, it is not. So you notice it says draft in the background. So there's a work group of our colleagues from the Ambulance Association, medical directors, fire departments, PSAPs, public health officials within the OHA that are all working to develop each of these squares and create documentation on how they flow together and what triggers, what are possible examples of triggers that might cause you to implement any one of these within your system. Are there any predictions of EMS workforce shortages planned? I know of no predictions for EMS workforce. We do have models for healthcare needs in general. Our current predictions with all measures in place right now is that we will not overwhelm our healthcare resources, but it is not specific to EMS workforce. Sure, this is a great question. Does the OHA mandate the triggering of crisis care guidelines, or this is a local systems decision, right? So these are strategies to be interpreted and implemented locally, as well as the triggers are. This is just strategies, this is just guidance, as we wanted to emphasize earlier. These are not rules, orders, or regulations. What does PSAP stand for? Public Safety Answering Point. So this is 911 call centers. There are no reporting requirements to use these guidelines. These are strategies that can be implemented in conjunction with local public health, local stakeholders, and in the context of your local EMS system. I don't see a ton of questions. Do you want to just talk about this matrix a little bit and give like brief descriptions? Can we bring the matrix up so we can just get a feel for this?
Okay.
Yeah, that's right here. So
Have you on pause?
if there are any more questions come in, we'll wait a little bit and bring the questions back up again. Sure. So let's just look at the dispatch. Implement EDIS card. So we've already put out, so the EDIS is the emerging infectious disease card if you're using MPDS, but if you're not, if you're APCO or if you're using the DPSST card set, we have guidance here posted on our webpage, and that guidance is sort of a generic, I have this. Let me just link to that. So this is the same guidance you'll find on our webpage, and it's a generic screening protocol that can be used by any PSAP if you don't have an emerging infectious disease card. And what it basically does is say, we know we're in the middle of the pandemic. We want to protect our first responders, so we're going to ask questions that we normally wouldn't. Do you have a fever? Do you have cough? Do you have shortness of breath? And that guidance changes depending on what phase of the epidemic we're in. You know, very early on, we were asking about travel to China. Then we were asked generalized to ask about travel outside the United States. But now that it's community spread, you know, that guidance has evolved into just ask these questions to everybody. So that's an example of EDIS screening. Pandemic cards do a lot of things. They were developed for influenza pandemics, but they provide you with options for triaging calls like shortness of breath, sickness, chest pain into a common pathway, asking some questions that would eliminate medical emergencies and make it highly likely that this call was in fact a respiratory pathogen, and then give you several options depending on the resources in your system. Some of those options might be delayed or not responding to low-level calls like alphas and omegas. It would provide, depending if you had the resources, medical triage in the PSAP. So that could be having clinicians in the PSAP that you could hand the call off to. That could be handing the call off to a call center if it met certain criteria. You know, and again, we provide, if you don't have a pandemic card and if your medical directors haven't supplied that for you, we have sort of generic information that's generic enough that it could be used by any PSAP as to how to screen a call that might be eligible for some alternate resource, a clinical referral line or a non-transport vehicle, etc. So again, it's designed to be very flexible within your system. There's alternate staffing at the PSAP. This might include having a local fire officer there to help triage the calls and provide alternate dispatch depending on how many rescue vehicles and ambulances you have in your system. And again, this is meant to be strategies and guidance, not to be followed rote. It's meant to be adapted, any one of these, into your system. Other strategies in the response phase might be deploy a non-transport vehicle. So you might roll an engine to a scene. assess the patient right there, and then determine the response if an ambulance is needed. Extend response times to certain calls. So in MPDS, this would be your alpha or omega calls. More generically, this would be your code 1 calls, things that you weren't going to go lights and sirens to. Other surge capacities, increase capacity by surging your units, alternate responses within jurisdictions, or closest unit regardless of jurisdiction. So this would speak to our ASAs and our RFPDs, going into more of a mutual aid mode or closest ambulance. When we've gone through all our surge to increase capacity by these several strategies, and we moved into crisis, we have raised the amount of units we can put out there and the way we're using those units to the maximum efficiency, and we still can't make our call times. Consider extended responses to call times, or again, non-ambulance responses. This could be if you did a medical triage at the PSAP, or an in-person triage with a non-ambulance vehicle and determined that the person just needed a wheelchair van, or they needed to go to the hospital. There was simply no other transport possible. Could we use a non-ambulance vehicle to get them to the hospital? Again, very, very generic guidance and just strategies for dealing with both surge and triage. During the transport and destination phase, we have transport to an alternate destination. So this could be an urgent care center. This could be a clinic specifically designed for to see patients with respiratory pathogens. This could be a different area of the hospital. So instead of going to the emergency room entrance you normally go to, there's an alternate entrance for persons with highly infectious diseases. Batching transports, again, it crosses the line between surge and triage. This is where you might send a unit out to go to several calls before you drop those patients off, again, at a specific site for patients with respiratory pathogens. And we go into the non-ambulance transports again here. For destinations, we usually take patients, stroke, STEMI, trauma, to a specialty hospital, their hospital of choice, depending on what their healthcare plan and where their doctors are. There's strategies to, during surge, when we need to keep more vehicles responding to calls, we can limit patient hospital destination choices. And then when we've maximized our capacity to do that, consider going to the closest hospital, plus or minus a transfer later for specialty care. Again, it's recognized this doesn't apply to every system. Many of our EMS systems can only go to one hospital because of the geographic distances. But it provides strategies for those that don't. And then alternate staffing and equipment. So this is where you might upstaff a BLS rig with a paramedic, or split a ALS rig and send paramedics on 2 different units. And then even in crisis standards of care, where you might consider having other public safety workers driving the ambulance and committing all your medically trained personnel to patient care. So that's the general feel for the guidance. And what the work group is doing now is developing content for each of these squares that'll hopefully be specific enough to be to help you develop strategies, but will be general enough that each EMS system can pick and choose what might be appropriate given the content of your system and where you are in terms of medical surge. So I think we'll pause again now and take any questions about the crisis care guidance as a general concept, about the categories of conventional, contingent, crisis, and the strategies of increasing surge and triage, or any specific feedback or guidance on how we're developing generalized organ crisis care guidance specifically for EMS. So there's a question of when it might be ready. We're hoping, it's a lot of content to develop, but we're hoping to have a completed draft going forward for review from the public health officials, hopefully by next week. And can I ask, does this look, are any of the things on this matrix already under development locally? So we're seeing responses that, and I have heard from my colleagues that certain parts of this are being addressed locally in different counties. We by no means want to slow down local development of crisis care guidance, but just wanted to give a quick preview before this was ready for public consumption, for general awareness that this is being worked on and that we are basing this off the previously published Oregon Crisis Care Guidelines. So we're starting to see some feedback now that certain counties have plans for many of these contingencies, that some metro fire departments have staffing swaps based on the need for effective response forces. That there's some auto mutual aid being put in place. Well, either I didn't do a very good job of explaining or I've done a great job of explaining. Thank you very much for taking the time to review this. Would appreciate any feedback. It is not ready for release, which is why we're doing it as a webinar right now, but we will try to get the formal document completed by next week, and start pushing it through the publication process, which could take possibly another week. If you have any questions or need any resource materials about anything you've seen here, you can contact our office and we can provide guidance for any one of these steps before the entire document is done. Thank you all very much.
Thanks, everyone. That concludes the webinar for today. This will be, the recording will be posted on our healthoregon.org/coronavirus webpage underneath the other previously recorded webinars if anybody needs to watch it later. Thanks and have a good afternoon.